Hello, everyone. Thank you so much for joining us tonight for Behind the Hope, Your Impact at Alex's Lemonade Stand Foundation. If you can hear me, let me know. Type something in the chat. Let us know where you're calling in from. We're just going to wait a minute or two here to let some people sign on. See the participant number growing. So again, let us know where you're calling in from in the chat. You can hear me. That's good. Thank you, Christina from Illinois. Lisa from Cleveland. Hello, Lisa. Chris, how are you? Thanks for joining us. Kim in Kansas. Awesome. Thanks, everyone. So happy to have you joining us. All right, we'll wait one more minute and then we'll get started. We have a good number of people here already, so thank you all for being prompt too. All right, I think we can go ahead and get started. So thank you again for joining us for this virtual event that we are calling Behind the Hope, Your Impact at Alex's Lemonade Stand Foundation. For those of you that I haven't had the chance to meet yet, my name is Lexi and I am the development manager here at Alex's Lemonade Stand Foundation. So a couple housekeeping items before we dive in. This meeting is being recorded, so we will send that around within the next couple of days if you want to revisit it or share. Also, if you have any questions throughout the event, please put them either in the chat or the Q&A, and we will save all of those for the end of the event. So if you have questions for any of our speakers tonight, feel free to pop them there. And before we get started, I just want to take a moment to say thank you and recognize you. This, of course, is an event to share your impact and what you made possible in 2025. So whether that means you hosted a lemonade stand, you donated, attended one of our events, volunteered, helped raise awareness and more, whatever you did in 2025 to help make our mission possible, we just want to say thank you. And that is why we're here tonight. So in just a few minutes, you'll hear from Liz and Jay Scott, our co-executive directors, Diane Anderson, mom to childhood cancer hero Lincoln, and Dr. Ted Johnson, an ALSF-funded researcher. But before that, we want to take a moment to share with you the origins of Alex's Lemonade Stand with a quick video. So give me 1 second here to share my screen. Make sure I have the sound going for you. Okay. And again, if you any audio issues, let me know in the chat.
When she arrived here, she was a very sick young girl.
Her cancer was just relentless at that point.
There's Alex.
During that month-long stay in the hospital where she told us she wanted to set up a lemonade stand.
I raise money
For what?
cancer research.
Alex's goal for today was to raise $1 million worldwide.
We were all thinking, like, that's so heartwarming, and we hope that that can happen, but could it really?
$1 million seemed like an impossible goal.
That's a lot of lemonade.
I see this little girl on Oprah, and I was like, oh my God. I said, that's it. And I called my wife up and I said, Nat, I found it. I found what we're going to do.
Alex, while battling her own cancer diagnosis, was thinking about all the other kids. It just grabbed me.
Just a donation, yep. Thank you very much.
Donate out lemonade!
She was at about 750,000, 800,000, and the donations were coming in every day. I said, but I don't know that she's going to be here to see that goal met. People were continuing to have lemonade stands and companies were supporting. And one day I got a phone call and was told that we were going to get a large donation to take her over her goal. So as soon as I hung up, I turned to her and I said, Alex, you met your goal, you raised $1 million. And she just sat up and clapped her hands and she laid back down.
I think once she got to that point, I think she was at peace.
She died 10 days later. So she was pretty clearly hanging on to see that goal met, and she did it.
That just gives you a little background. For those of you who aren't familiar with Alex's story, that's actually a shortened version of our 35-minute documentary. So if you're interested in seeing an expanded version of that, you can find that on our YouTube. And I hope you think about Alex's story as we go through the event tonight. It's amazing what one little girl started, but it continues because of you and the support that you provide to help further our mission. So thank you again. Now I'd like to invite Liz and Jay to unmute. As you saw in the video, Liz and Jay Scott are the proud parents of Alex, and they are also the co-executive directors here at Alex's Lemonade Stand Foundation. So Liz, I'll start with you. So in 2025, there were more than 15,000 lemonade stands and events in support of Alex's mission. So when you think about from one stand to now 15,000 a year, what does that mean to you?
It is hard to put into words, but you know me, I'm going to try. Almost 26 years ago, Alex started her lemonade stand. We didn't think it would make a huge impact in the world. We thought it was important to her. Never could have imagined that now we'd be sitting here talking about 26 years of impact, over 1,500 research projects funded, thousands and thousands of families we've helped through our family services, started a data lab to help researchers better use their data and make data more accessible to help us get to cures faster. But really never could have imagined the community that would be built around her lemonade stand. And I think the people on this webinar are a great example of people who just care a lot about children with cancer and care a lot about making a difference. And I'm so grateful to Alex for bringing those people to us, because it's truly a gift to know each and every one of you, whether it's through your donations or because we know you personally. So honestly, I just feel grateful.
Yeah, absolutely. I mean, I can attest to that the Alex's community is some of the best people I've ever met. So my next question is for you, Jay. Last year, Alex's also funded nearly 300 new and ongoing research projects. So is there a recent breakthrough, a project or initiative that was really exciting in 2025 that you'd like to share with our supporters today?
That's a great question, Lexi. I'm excited about a lot of things. I'm always excited about some of our family services, like our Travel for Care program, which helps families that need to travel to get a treatment, because the same treatments aren't available everywhere. But as far as research goes, I'm really excited about that we were able last year to fund a lot more young investigator projects. Young investigators are really important to the future of childhood cancer, and funding for young investigator projects has taken a hit lately. And we wanted to sort of help that group of people get their first grant, ensure that they become childhood cancer researchers and stay childhood cancer researchers for years. And so we were able to up the number of young investigator projects we funded by 50%. But probably the most excited area that I'm excited about from 2025 is from our Crazy 8 initiative. There were two new projects, and these are large projects. And one of them is looking at having the ability to identify kids that have a predisposition for cancer at birth, and then coming up with a way to identify these kids and let the parents know that they may have a predisposition, and then follow them with certain protocols. And then the second project is looking at ways where they can intervene with these kids that have predispositions and treat them in a way that the predisposition never becomes cancer. And so that's a way to, for some kids with cancer, possibly prevent them from ever getting cancer. And that's like the holy grail, is prevent the kid from getting cancer. So those are the things that I'm most excited about from last year.
Great, thank you. And then staying in that same vein, Jay, are there any initiatives coming up in 2026 that you're also excited about?
Oh my goodness.
Right, so many.
Yes. So staying in the thought of the Crazy 8 initiative, where these big projects, I mean, the Crazy 8 initiative is large projects. We've only been able to fund these type of projects over the past few years as Alex's has been able to grow. But just to give you an example, one of the projects was a $5 million project, and they were able to take that work and turn it into a $25 million grant. So they turned our 5 million investment into 25 million to further the work and bring what they're working on to more cancers into kids and hopefully down the road in other parts of the world where they're not able to get the same treatments as we get here. So leveraging our money. But in 2026, we're going to fund two of those Crazy Eight projects looking at brain tumors, which is a huge problem in childhood cancer. And we don't have a Crazy Eight project that only looked at brain tumors, and now we're gonna add two this year.
Yeah, it's exciting. So stay tuned. We'll share more about those later in the year. But my last question is for you, Liz. So it's been more than 20 years since the start of Alex's Lemonade Stand Foundation. What inspires you to keep this mission going?
Easy answer. It's the kids we meet, the kids and the families, whether they're kids who are fighting, kids who have fought in the past and survived, but their lives and their families are forever changed, or kids like Alex, who are no longer with us. Those stories are really what drives us every single day. They're at the forefront. I mean, the pictures behind you and, our conference room walls, our office is filled with photos of kids. This is what inspires us. And, we're so fortunate that Alex was the spark, but it's so much bigger than Alex. And, she was the spark that inspired so many, but it's really the kids who are out there fighting and the families we've met along the way that keep us all motivated. And for me personally, it's my biggest motivator that there is. Like, how can you not do more when you know that there are kids getting diagnosed today or that, are still fighting or, could relapse? How could you not do more when, kids and families have fought so hard and maybe their kids didn't make it? Um, that's the top of mind for us. And so if it ever gets discouraging or hard, uh, we just keep our eyes on the prize, I guess you would say, and that is really making sure that we can do better for all these kids.
Yeah, absolutely. Well, thank you, Liz and Jay. A reminder, if you have any questions for any of our speakers tonight, please put them in the chat and we'll address them at the end. But for now, I will turn it over to you, Liz, to speak with our special guest for this evening.
Okay, I am very lucky that I get to do this because we have two incredible guests here, and you're going to judge for yourself why I'm saying that. And trust me, you will feel that way. I do have to give sort of the formal intro. I will say, whenever I'm introducing researchers, I always abbreviate it. The credentials for Dr. Ted Johnson could go on and all the titles that he has, but I always feel like, first and foremost, just incredible human beings who go into this field. So all the slickest bios in the world don't necessarily represent that, but I can tell you we're really fortunate to have someone like Dr. Johnson working on behalf of kids with cancer. He is a pediatric, now the boring stuff, he is a pediatric hematologist, oncologist, and co-director of the Pediatric Immunotherapy Program at the Children's Hospital of Georgia. He received his MD from the Medical College of Georgia. And then just because I can't remember the order on this, he also got a PhD in molecular medicine from Augusta University. This guy really likes homework. No, I'm kidding. But more importantly, he's driven to use all that brain power and the knowledge he's gained from that education to help families. He has received more than 2.3 million in funding from Alex's over the years, beginning way back in, I believe it was 2013, when he received one of our A awards, which is designed to support the best of the best researchers early in their careers with the hopes that we can encourage them along the way to bring innovative new therapies to children with cancer. And since then, he has definitely fulfilled that promise, because not only that, but he followed up very quickly with another large grant from us to translate his work into a clinical trial for children with progressive brain tumors. And since then, he has had one of the most active participating teams in our annual Million Mile Challenge. Shout out to everyone on this who participates in the Million Mile. He has led a team that has raised over $400,000 over the past 11 years. And all of this has gone back to support his important work in helping children with brain tumors. And our second special guest has a very special connection to Dr. Johnson. Diane is mom to Lincoln. She and her husband, Eric, and their daughter, Hadley, and her son, Lincoln, you're still in New Hampshire, right? Live in New Hampshire. nice and balmy, beautiful weather you're having there probably this time of year. Lincoln was diagnosed with a rare brain cancer called ependymoma when he was 3, and he fought for many years. She has generously agreed to share her family story with us, so I am not going to share it on her behalf, but I do want to thank you for being so generous. If you follow us, you've probably seen little bits of Lincoln's story before, but you're going to hear firsthand tonight. We're so happy to have you both. Okay, so Ted, why study pediatric cancer? It sounds like you could have studied anything with the background that you had. What drew you to dedicate your life to caring for these kids?
Wow. So, I did do an MD PhD combined degree pathway. And so I was very involved in research through my medical training, including in my residency and my fellowship. And so I didn't decide on a fellowship until pretty late in my second year of residency, which is a little late in the game. But my dad was diagnosed with multiple myeloma and had a transplant and passed away when I was an intern in pediatrics. And so I wasn't really sure that I would go into cancer research or oncology. But I did a visiting rotation as a resident at another large medical school in our state that did have a bone marrow transplant program. And I was able to get exposed to the kids and the families. And some of the kids were there that were there came from our institution, and I knew them. And some were doing well and some were not doing well as things go. But it really kind of consolidated my thoughts. I was always looking for some discipline that I could continue doing research, and oncology is a really target-rich environment for doing research, and sort of marrying that with what you do in the clinic. So, and then of course, I just fell in love with the pediatric patients. I could have gone into adult oncology. It sure pays a lot more, but it's a lot more rewarding, I think, to be in pediatrics.
So you've done something. Well, first of all, I want to talk for a second about your A award. Was that your first award grant that you received on your own?
So when I came back to Georgia with a lab startup package, and after fellowship, I finished fellowship in 2010, and this A award, I just looked it up before we got on the call, and I got the letter in November of 2013. So my startup package was a 3-year package, and it's, July to June. And so in July of 2013, my startup package was finished. And my department chair was breathing down my neck. I had
days were numbered.
75% of my professional effort was dedicated to research, and it still has and always has been. And a big part of that is because of the 55% that Alex has covered on that A award for 3 additional years. So I was probably 6 months away from getting pulled into the clinical conveyor belt of just seeing, everybody wants to see patients, but if you're going to build a research career, you have to have protected time also in order to really focus and make advances. And I feel like if the timing of that had been a little bit different, my whole career trajectory may have been different.
Wow.
Honestly.
So yeah. I think you hit on a lot of things. I think the importance of investing in young researchers at the right time so that they can build a career. But I think your passion for research combined with your passion for caring for patients has allowed you to do something that I think is what we hope all our researchers can do. You took what you were seeing in kids into the lab, you studied how to cure these cancers in the lab, and then you actually brought it to clinic. I know we gave you a biotherapeutics award to get that trial going. Can you tell us a little bit about the trial in as non-sciencey as you can get?
Sure. So first of all, you said earlier that we translated what we were doing in the A award into the clinic, and that is true. So that the Biotherapeutics Impact Award was awarded in November of the following year, but we made so much progress in that year that we convinced the drug company to partially fund the trial, provide drug, do all the regulatory support. But that drug company was waiting. I don't know if you guys know this. That drug company had a hard stop on our trial unless and until we could get funding from outside sources in order to show them that it had been vetted scientifically and that the scientific community and the pediatric oncologists agreed that this was worth doing and important and impactful. And so they weren't going to spend their, pot of gold until they knew somebody else was putting skin in the game. And it was that biotherapeutics impact grant that started what became a bit of a slippery slope. I looked at the data that we submitted to you guys for the A award, and it was very rudimentary actually compared to what we actually now know. But that's the nature of research.
That's progress, right?
The snowball goes downhill very fast. So, yeah. In furtherance of that, we've fast forward to today, we've now treated, over 275 kids on the indoximab trials across all the different trials. We had the phase 1 trial open, and it ran for about 4 years. And then we opened a phase 2 trial that was a follow-on, exactly the same treatment, but enrolling more kids that were, cohorted into specific diagnosis cohorts so that we could see who was actually responding. We've opened other trials and expanded access protocols, but it adds, we've had patients from six international patients from 4 separate countries and 33 different states across America coming for indoximab therapy. And at this point, I think we're at 276, and we've got a few that are going to enroll in the next few weeks. So
I love that you know exactly how many. I think it shows the care that you take, and it's not a number, right, in every single child. So that brings us to you, Diane. Can you tell us about Lincoln's diagnosis, what you all went through, and how you ended up meeting Dr. Johnson?
Sure, of course. Thank you for sharing Lincoln's story. So Lincoln, when he was 3 years old, as you said, was diagnosed with a brain cancer called ependymoma. He underwent the primary treatment, which is surgery and radiation. A little over a year later, after monitoring, he had a secondary lesion in a different part of the brain. Again, underwent surgery, radiation, and a year on the only approved chemotherapy for ependymoma. And unfortunately, he again then relapsed with a third tumor. So this time, our team up here in New Hampshire had to come up with a new plan where he failed on the only approved chemotherapy for ependymoma. And we were lucky enough at that time to meet with Dr. Johnson's team way down in Georgia, all the way from up here in New Hampshire. So I think you can imagine what that brings. I had to be out of work to care for a sick child with cancer. And we had to figure out how to get to Georgia once a month for a year down to Dr. Johnson's trial. So Alex's Lemonade Stand Foundation, we were introduced to, and not just were they funding an amazing trial and research that's so important in pediatric cancers, but we got to participate in the Travel for Care program. So they helped us with flight expenses down to Georgia for myself and Lincoln to go down for the treatment for the indoximab trial. And we then, continued with surveillance and treatment as well up here in New Hampshire. We stayed on that trial for a little over a year. And not to be excluded, but Hadley, his sister, was also in the Super Sibs program. So the other amazing thing that Alex's does is they include siblings, and she would get once a month little treats in the mail, like recipe guides for making popsicles or a birthday card for her birthday. It's such a well-rounded, well-thought-out foundation with this amazing spark that Alex started of research to helping this well-rounded system of the entire family being thought about. And not to bury the lead, but I will tell you that Lincoln is now 3 years off treatment and cancer-free. So,
wow. I think that
he's doing
if I
great.
could find my reaction button, I would be giving a lot of hearts and applause. I know we got to see him briefly when we had a call the other day, and he looks great. How is he feeling?
He's doing really well. So he will continue to have surveillance the rest of his childhood up through early adulthood. But he is thriving and a very happy 12-year-old boy. So we are amazed and grateful at all of his teams of amazing doctors we are so fortunate to have, including Dr. Johnson. And the amazing foundation that we can't imagine all the families you have helped. And we've run our own lemonade stand ourselves.
That's right. I forgot to mention that.
Any way that we can give back. Like I said, the amazing foundation that helps so many families like ours. We are so grateful to all of the donors and just amazing work.
Can you describe, I know, we were, every case is different, but we were similarly, at a point with Alex where the sort of known cures, what everything they had that they thought might work hadn't worked.
Yeah.
Can you describe, first of all, how did you find out about Dr. Johnson's trial? And I don't know the answer to this, so I'm actually asking a serious question, sincere question. And then what did it feel? What was your feeling about it? Were you optimistic? Were you hopeful? Were you skeptical, but we'll try anything, all of the above?
Yeah, so our team at Dartmouth is very knowledgeable and open to clinical trials. So we knew going in that there was only one approved metronomic schedule of chemotherapy for ependymoma. So they had talked to us, throughout the treatment, and when the new tumor popped up, that we're going to do surgery, we will remove it, we'll do the best we can, but we're going to look into networks about clinical trials with his type of cancer, because they were able to remove the tumor, even though there could be cells floating around to these satellite lesions he's had. The options for clinical trials were very limited. But we met with virtually at the time with Dr. Johnson's team. They explained how Indoximod was working, what successes, what they were seeing with their trials, the effects they were seeing with kids. And I knew, coming from a medical background, I felt comfortable, and I'm sure you feel the same way. Anything for your kid, if it meant going halfway across the world for treatment, we were all in, and we were very comfortable jumping in and heading to Georgia.
You felt that he was offering you some hope.
Yes, it was hope where we didn't have much, knowing that the current approved treatments had not worked the last time. So we were happy to find some hope for a kid that didn't really have many options for ependymomas, unfortunately.
So Dr. Johnson, what would you describe as sort of what's unique about your trial that you're able to help so many families? Because I think that's a really impressive amount of kids you've enrolled. So I would love to hear what makes it unique and why you were the only option. I'm assuming it's something to do with the uniqueness of what you're doing.
So a couple of background points. Ependymoma at the time, and probably still true today, is just sort of not been well represented with clinical trial options. The clinical trials tend to focus on glioblastoma, medulloblastoma. Sometimes they're any type of solid tumor because it's a brand new drug. They're just trying to see if they can get the right dose, but it's not really meant to help ependymoma. And so the ependymoma patients, I think, have long been underserved. And we just included all pediatric brain tumors in the phase 1. And when we did the phase 2, we had our phase 1 trial enrolled 81 kids because we had not just dose finding, but expansion cohorts. Because we didn't know when we would have an opportunity to open a phase 2, and we just kept enrolling kids until we knew that crystallized and we could open the phase 2. But at that time that we closed the phase 1, out of 81 kids, 27 of them, which is a third, were ependymoma patients. And so it just illustrates. And then, that was our highest group. We had, I think 13 medulloblastoma and maybe a similar number of glioblastoma, and then 12 or 13 DIPG and a smattering of really rare things. So we knew the ependymoma patients were underserved because they were coming from all over the country. My clinic is now 95% out-of-state patients. They fly in or drive in from all over, like I said, and they're motivated because there's no next step therapy. When you have really any pediatric brain cancer that relapses, there's maybe one or two off-the-shelf go-to options that may provide some benefit. Not a guarantee for cure, but sometimes to slow the disease down or get a response that lasts a while. But most families are told at the point of relapse that this is a very grim place to be in your overall journey, and people don't pull punches on those conversations. So the ependymoma families have been very motivated, I think, because they don't have local options. There aren't go-to options. One big advancement that has developed for that population is reirradiation, which nobody was doing when we first opened our phase 1 indoximab trial. And we were combining indoximab with radiation. So indoximab is an immunotherapy, and we combine it with radiation and chemotherapy. And there's a scientific reason why it has to be combined to activate the immune system. So we were already doing reirradiation, and the field began to turn on this point because a few very savvy researchers around the country, Boston and St. Jude and a couple of other places, were having good experience at temporizing or providing significant duration of remission in kids with ependymoma after radiation. So now it's sort of the go-to thing to do radiation, but we included it in our trial in case someone might need it, so we could use it, and it was an option. And we had a lot of kids who got radiation plus indoximab. And the idea is that the radiation damages the tumor a little bit so that the immune system can see altered proteins that you weren't born with, sort of like a mismatched kidney, and the immune system can attack on the basis of those altered proteins, attack the tumor, like rejecting a mismatched kidney. And the same thing with chemotherapy, which we give. And the kids who got radiation, we followed that with cycles once a month of 5 days of chemotherapy. The chemotherapy was all oral. The indoximab is an oral drug. So we're talking about treating you for your brain cancer, and in some cases, creating really long-term remissions with just oral therapy.
Wow.
No infusion, no infusional drugs, no time in the infusion room. When we're only using the chemotherapy to damage enough of the tumor to trigger immune responses. So we don't have to push the chemotherapy to highly toxic effects.
Right, you're not pushing it to the max.
Exactly. If chemotherapy is all you have, then you have to eradicate every tumor cell with your chemo, and you accept all the side effects. The low blood counts, the transfusions, the time in the hospital, the infections, all the other things that happen that damage your organs. But at the first sign of intolerance, we drop the chemo dose by 20 to 25%. If you need a transfusion, one transfusion, you drop your chemo dose. And most of the time, that's enough for you to never need another transfusion. A handful of kids needed 2 dose reductions, but that's the overall strategy. And it doesn't affect our outcomes because if this treatment works for you, the immune response that is facilitated by the indoximab can be 10 times stronger in tumor killing than the initial chemo damage.
So you're revving up the immune system to respond. I didn't realize it was all oral. That's incredible.
It's all oral. And over the years, we learned a lot about things in our eligibility criteria that made it hard for, if there was something that made that, maybe it was of academic interest, or there was something that an adult oncologist might insist on, but it really didn't make sense. That why would you screen out those patients? So we eliminated a lot of the roadblocks to enrollment. I can usually tell with about 98% certainty over the phone with a 1-hour telephone conversation with families whether or not we can enroll them. And that way, and I have a 1 to 2 hour conversation with every family that comes to Augusta, and I don't bring them to Augusta if I know they can't enroll. So we don't waste their time that way. But if we get off the phone and we know we can enroll them, then they can discuss it as a family, and they have high confidence that when they get here, there's a couple of things like an EKG. I don't know what that's going to show until we get one. The labs. So I've had a couple of patients who've come over the years who they got here and their labs weren't good enough to start, and we had to wait on that. But most of the time, it's a very, very easy enrollment process. And we're also a very rapid. So from the very beginning, we wanted to, people are removing themselves from their support networks. They're traveling across the country. It is a fragile sort of emotionally fragile time, and it's an emotionally fragile setup for folks. So we wanted to do things that would make all of that a lot easier. So one of the things that we did very early is we figured out a way to rapidly onboard new patients. So we can, the only thing that slows us down is getting records if that is a lagging process. But usually we can get on the phone with a family. If they want to come to Augusta, within 2 or 3 days, we have all the records we need. We can meet them on a Monday and start them on treatment on a Wednesday. Most families stay in Augusta the first 2 weeks just for safety monitoring. And after that, they come back once a month for overnight visits to get refills on their study medications. And so that, the ergonomics of that and the predictability of that. If we need to do labs, if we're worried about low counts, we do those before you travel so we can transfuse you before we travel. And then we drop the dose so it doesn't happen again, right? So we don't want you traveling with low platelets on a plane with a brain tumor. And so we've done those things over the years. We just took it under advisement whenever we tripped over something that looked like a problem that would create a safety issue or create an ergonomic or a logistical issue for families. And then early on, the travel, of course, is a big commitment for families. I had some families who did crowdfunding, and all of the international families that came crowdfunded. And that's because they're not insured in the United States. And so that's a whole different bucket of worms. But the Travel for Care program with Alex's started really close to when we didn't enroll very many patients on the phase 1 trial before that was available. And the team at Alex has reached out to us because they knew we had the trial open, and they said, look, for our funded trials, we want to be able to try to do this. I don't know if you guys knew what you were getting into, because we've really used that over the years.
We want people to use it because of families like Diane's,
Right.
that we want to know it's available. We want to help. Last year we helped well over 300 families. I think you referred many of them, but certainly not all of them. We have institutions all over the country. Oh,
I
there's
wanted to
Lincoln.
say hi.
Special
Hi.
guest.
Thank you. Thank you.
Hi, Lincoln.
Thanks for joining us, Lincoln.
You can go.
Okay, so I'm waiting to see if we have questions from others. I don't know, Jay or Lexi, if you have questions, because I could hog all your time and keep going.
I had a question for Dr. Johnson, and actually I had a couple, but the first one was, do you ever see the ability for this to expand to other types of tumors, this trial?
Oh, yes. Oh, absolutely. Our bandwidth has been limited by the company that makes the drug is a small biotech company, and it's been merged and bought and sold, and so we have rolled with the punches with each one of those changes in management. But for the clinical trials, we have contracts that obligate them to continue giving us drug even if there's a change in management and that sort of thing. So we've managed to toil away in our little microcosm while the company became a company that focused on a growth hormone pipeline. And now the data is good enough that they're actually really excited about. We've been in discussions with the FDA about how to design a phase 2 registration trial to go for approval at some point. And those are very serious negotiations and ongoing. And hopefully in 1 to 2 years, we'll see that trial open. And so we have focused on the brain tumors, but we knew all along that the immune system doesn't care what the name of your tumor is. It only cares that it has altered proteins by virtue of all the mutations that stack up to create the cancer. Those altered proteins you weren't born with, and that's what in nature, in fighting infections, that's what your immune system targets, is proteins that are in your body that are not supposed to be there. And so as long as the tumor, whether it's a Ewing's or a neuroblastoma or a leukemia, as long as there are mutations and altered proteins, there is a great potential that the immune system can be a player in fighting those. And so for that reason, that indoximab could have a role. And so yes, down the road, we think that the way to make this drug available for widespread use is to get it approved for any indication. And once it's approved and available commercially, the cooperative groups like the Children's Oncology Group can add it to regimens they already have, if that makes sense, for all sorts of cancers.
Does make sense. Yeah, that's the way to reach the most kids.
Yeah.
So Diane, I have a question for you. So now you've been, I guess, out of treatment. I know there's still a lot of follow-up for a year plus or 2 years plus.
Well, Lincoln was, he's had MRIs every 3 months. Then
okay, that's what I was going to ask. So what is life like now? What are you still doing and thinking
currently,
about?
This is the longest we've been between MRIs. Right now, this is the first time it'll be every 6 months. And that will be for the rest of his childhood. Ependymomas, unfortunately, are sneaky little cells that can come back the rest of his childhood. So even though right now he is cancer-free, he will be screened the rest of his life. And he does have some complications from, all the surgeries and everything that he is continuing to thrive through. But yes, he will be screened the rest of his childhood. So.
Yeah, and I think it's important for our supporters to know that, it doesn't end because he, currently is, I guess, no evidence of disease or stable, right? This is a lifetime
It is.
diagnosis.
It's a
Yeah.
lifetime. And, every MRI is the same as the previous. There's always some worry. The mom groups call it scanxiety. And over the summer, we had a little blip that ended up being some scarring, and it all comes back. You
It all
always
comes
worry.
back, right?
Yep. And, he takes it in stride. He's the easiest kid with medical stuff, thankfully. So he's super easy about it. And every time I say we're going to Dartmouth, he gets excited. I don't know. He's pretty easy with this stuff, fortunately.
And how is Hadley doing? She's, what did you say, 15 now?
15. Yep, she's doing great. She's getting ready for driver's ed, and now that we can, do some focusing on her, she's got a love for volleyball and being a teenager. So
good.
It's hard on the siblings. They have to take a back seat for a while. So any chance they get to be in the spotlight or a little special thing for them is an amazing treat too. So we tried to make it special every time we went down for radiation treatments. She always got to come. And, when he was really sick and we had to pull her out of school during COVID, we made things super special for her too, which she always, it's the whole family unit that is involved when it's pediatric cancer. It's a lot, but you get through it together. It's the only way you can.
We do have a question, Dr. Johnson. Someone asks, I'm curious how you came to develop this drug. Can you tell us a little of that story?
Yes, actually.
It might not be a short story, but maybe the highlights.
I'm not famous for short stories. No. So seriously, stop me if I'm talking too much, but the drug was invented here in Augusta, Georgia. Excuse me, at what was called the Medical College of Georgia at the time. We're now called Augusta University, and the Medical College of Georgia is a unit in the university. I did my PhD in one of the two labs that discovered the target of indoximab, which is a protein called IDO, which is expressed in specialized immune cells that govern those immune cells decide whether or not you're going to have an immune response or not have an immune response to every fragment of protein that floats by. And so they're the first line shock troops, and they make the gateway decisions of whether or not you're going to have a robust immune response, or if you don't have a robust immune response to that short protein fragment, usually the immune system is turned off so it doesn't accidentally target that protein fragment. That's important because you don't want your immune system targeting your own tissues. If that's a protein fragment you were born with, that's called autoimmune disease like lupus, and you don't want your muscles or skin or organs to be targeted by your own immune system. Honestly, people don't realize, but the COVID pandemic, what was killing people on the ventilators with COVID was their immune systems. Their lungs were filling up with so much fluid from all the inflammation that they couldn't get air into the lungs. And that's why people were dying. So you literally can have an immune response that is too strong, out of proportion to what it needs to be, that can hurt your body and even kill you. So this IDO protein, part of what it does is regulate the immune system so you don't have these hyper intense immune responses when you shouldn't be having them. The other thing that the immune system does is it helps to heal tissue that's been damaged. If you have a burn or a scraped knee or a crush injury and the muscle is damaged, it's your immune system that pumps out all the growth hormones locally in that damaged tissue and all of the proteins, the messenger proteins that are called cytokines and chemokines that bring in the other cells so the immune system is conducting the symphony of that wound healing process. So you can, and usually it's a decision of whether you do one or the other. And IDEO is one of those nodes where that decision is made. So if IDEO is turned on, immune responses are suppressed, wound healing is promoted. If IDEO is turned off, wound healing takes a back seat so you can fight off whatever isn't supposed to be in your body. And so the IDEO the IDEO protein and the pathway were discovered by the lab that one of the two labs that discovered it, I did my PhD work in actually. And the guy that was in the other lab is the one who recruited me back to MCG to open a lab here and to open a pediatric phase 1 development program. We opened the very first phase 1 trial in pediatrics that this medical college ever opened.
Wow.
And
that's an accomplishment.
Yes, and it was an immunotherapy trial based on a drug that was a pathway that was discovered here, a drug that was invented in the same lab a couple of years later, and licensed to the drug companies. So the university has the patent rights. I don't. My partner doesn't, but the university does. But the university doesn't know how to be a drug company, so you have to license that to a company that knows how to navigate the FDA.
Right, so this is a pretty intense, complicated process.
Yeah.
But you were in the right place and you were the right person at the right time. You were able to say, I want to use this in kids. Was it used in adults first or straight to kids? It was. That's what I thought.
While I was off, so I graduated medical school here and got my PhD, and then I did a pediatric residency here in Augusta, and then I left Augusta and went to Cincinnati Children's for my fellowship. And while I was at Cincinnati Children's, I heard through the grapevine that they had gotten started in adult trials with indoximab. So adults with cancer were getting it in a phase 1 trial. And then by the time I finished my fellowship, there were a slew of phase 2 trials open. So I actually had a job all lined up at Cincinnati Children's to be a bone marrow transplanter and in immune deficiency patients who get bone marrow transplants and that sort of thing. And but they were sort of late in getting their contracts out, and one of the old timers here retired, and the guy who's now my partner but was running the lab that invented indoximab picked up my CV one day because they had decided to bring me in for a clinical job, and I was going to interview, and honestly I was going to try to get more money out of Cincinnati if they made me an offer, but they turned it into a scientific recruitment and offered me a lab startup package and the idea that there was nobody here with a clinical trial program that was that with their own priorities that would be sort of this is sort of ambitious at the time because I was just out of fellowship and but who thinks that way, right?
Well, I would say that's the time to do it because you can do anything.
And I was thinking, there's all the building blocks are there. They have a phase 1 trial office for the adult side. They have all the coordinators. They have the regulatory. They have everything I need. Nobody's put it together for pediatrics, and and so I can do that, I think. And that's really what drew me back to Augusta was that opportunity to bring, immunotherapy was a very rare thing in pediatrics at the time. This is 15 years ago. I mean, and so to open the first phase 1 trial for any kid with that whole class of drugs at the time, IDO inhibitors were very popular for drug companies to have one. It was a feather in their cap. Everybody wanted one, and nobody was ever going to treat kids and I know that because none of them ever have, and even today we're the only ones who ever have. I have pictures of the first child who ever took indoximab. I have pictures of the first child who ever took liquid indoximab with it mixed in water. I have, so that was just the idea that we could we could do something that unique was, I mean, with a lot of effort, but that's what really drew me back in.
So we have just a couple minutes. So there was another question for you, and then I know we're going to have some closing remarks, but looking ahead 5 to 10 years, what shift in childhood cancer research do you believe will make the greatest difference for kids and why? Is it a shift, I guess, is a question. And if so, what is the shift?
Right. So that's a overarching question. When I was in fellowship, pathway inhibitors were all the rage, and they were going to change the entire face of oncology treatment in kids. And there are some stories where that panned out, and they made CML is a great example where they made a huge difference. And they're doing personalized medicine with pathway inhibitors now, where they're combining, 2 or 3 or 4 of these drugs based on genetic testing and functional testing in the lab of your own tumor cells to find out what they will be sensitive to. So I think that's got a lot of potential and upside. I like to say that if the type of immunotherapy that we're working on is really unique in the sense that everybody else is working on immunotherapy where they directly activate T cells or they engineer T cells that are on a hair trigger. We're trying to activate the immune system from the ground up using its natural processes that create all the natural inflammation that you normally would get with an endogenous immune response that comes from your own body. It's the most natural way to stimulate the immune system. And it's the most personalized medicine in the world because your own immune system will go hunt down individual cells that aren't supposed to be in your body. It's what it's made for, to hunt down individual infected cells. It also will leave behind immune cells that have memory that can reactivate if you ever have a relapse. So to me, I'm doing personalized medicine with the immunotherapy that we're doing. And I think that's something that is going to grow over time too.
Right. And I think the fact that it's taken orally is probably a game changer in a lot of places. Okay, Lexi, I know you have a couple of closing remarks. I want to thank you, Dr. Johnson. I want to thank you, Diane, so much. Everything we do is to make sure that families like yours can have positive outcomes as possible. And just really grateful that we have the opportunity to meet you and to hear from you. And I'm sure all our donors appreciate it because this is what they are all making possible. Without support from this community, none of this work would be taking place. So I just want to say thank you before I turn it back over to you, Lexi.
Yeah, thank you, Dr. Johnson, Diane, Liz, and Jay, for sharing with us tonight more about the impact of our supporters. And thank you to everyone for taking the time out of your day today to join us. We hope this inspired you to keep your support going in 2026. If you're interested in finding new ways to get involved or ways to increase your support, let us know, reach out. We're always happy to share more about ways to get involved here at Alex's Lemonade Stand. So thank you all again, and we hope to hear from you very soon.